And I would like to welcome you all on this Tuesday evening to Residency Hot Topics. I am so excited to welcome back a friend, Dr. Adrian Louw. He has taught for our residency program, I think 4 times now, is an absolute world leader in pain management, and is someone that I thought of immediately when thinking about who can teach residents, residency interested people, and others who want to grow and develop the most critical information about pain that they can use in their clinic. So without further ado, love to welcome Adrian to the floor, and it is all yours, sir.
Thanks, Ben. Thank you, everybody, for joining us. There's a lot of better things to do tonight. I think Skinwalker Ranch is on. I think there's some other programs going on. But I do appreciate you joining me tonight. Yeah, Ben is a really good friend. I live vicariously through his life. Ben is an amazing angler, and we always talk fishing. And so I think we should do one of these sessions on fishing. That would be cool. So thank you so much for coming tonight. First of all, I do want to say that if you are currently in a residency, planning on going to residency, you're on that residency path, I applaud you. I think the world of you. You guys are the tip of the spear. You're the best of the best. I really do believe that. I've been a therapist for many years. I'm not going to tell you how many years. And I really revel with people that want to become the best of the best and try the best and better themselves. So I do want to applaud you tonight. Really, absolutely. I'm not saying that just because I'm here, but I work around a lot of higher education, post-professional education, residencies, fellowships, whatever. And so I really, really think you guys are doing something very, very cool. So what I'm going to do tonight is I'm going to quickly share with you my slides now. Ben has the handouts. We'll get those to you guys as well. And what I really want to do is I just want to quickly share with you my slides, and hopefully Ben can tell me if I'm doing it right or not. If he got it.
Looks great.
I think we're good, right? And so the question was, what would I share with residents about pain? There's so much information. And a few years, well, not a few years, last year, I was asked to speak at a big conference, and they told me you got 20 minutes to speak in front of a very large audience. And what is the one thing that excites you the most about pain? And I chose this topic. Right now, the hottest area in pain science is we call pain phenotypes, as pain categories or pain mechanisms, depending on what you read. And I wanted to share this tonight, and I wanted to try and convince you tonight why it is so important. So first, what I'm going to do is I'm going to run through it at a relatively quick clip. A, you have the handouts, and B, I think the fun will really be in the conversation when you guys ask questions, and I can just kind of give you guys some ideas and thoughts, and at least my opinion. So what many of you don't know tonight, maybe some of you guys have met me, maybe some of you guys have read some of the papers we do. This slide that you're seeing right now, the one in the middle, not the big one, changed my life in 1996 because this is how I got into pain. I was a manual therapist. I was trained very extensively by Jeffrey Maitland. I was working with very complex patients. I couldn't work with them, didn't know what to do with them. And then in 1996, at a class in Dallas, Texas, of all places, none other than the famous David Butler put this slide in front of us, and it absolutely changed my life. And I'm super excited to bring it to you guys tonight, not because it changed my life, but this little slide is actually currently the hottest topic in pain in the world. And when I say in the world, it's not therapy. It is not manual therapy. This is now being published in medical journals. And us pain people are beginning to say, well, it's about time you guys wake up. And so I'm super excited that this thing has come full circle. So let's take you through this process. In 1996, I was taught to reason the following way. And it's an old slide, but I wanted to keep it because this is the original one that David Butler showed me. But if you showed up in the clinic with pain right above your, right around that SI joint, if you will, we'd go through a very elaborate reasoning process. Is it a joint? Is it a muscle? Is it a tendon? By the way, if it's a muscle, which muscle is it? If it's a joint, which joint is it? In this case, you may say, well, I think it's a joint. It sounds like a joint. You can decide, is it disc or is it facet? Is it the SI joint? And you'd reason your way down. And what the pain mechanism model really taught us in 1996 is that pain can also be broken down from just this word pain to subcategories to help us reason better in the clinic. So in 1996, this came out. In 1998, it was published. And then in about 2009 to 2012, sorry for the history today, an amazing series of papers showed up. There's a gentleman in England, his name is Keith Smart, and he's got the perfect last name because he's smart. And he basically showed us from an enormous amount of research that when a person sits in front of you in the clinic, their pain is driven typically by one of three main mechanisms. It's either nociceptively driven, which is really any innervated structure, joints, muscles, tendon, ligaments. Peripheral neuropathic, which is any neuropathic pain that's from the dorsal horn out. And you and I would call that things like lumbar radiculopathy, cervical radiculopathy, carpal tunnel, cubital tunnel. And then the classic one, right? The one that always shows up on Friday afternoon in the clinic, central sensitization, right? We see these categories. In 2012, Keith Smart took this original concept from Louw Gifford and basically said there are three of these mechanisms. And just hear me correctly tonight, there was only about 11 of us in the world that believed this. We gravitated to it. We were so excited about it, but nobody was doing anything with it. And we were teaching it. Ben knows this. We were traveling around the country, putting up our tent every weekend, telling the story and telling the story. And it's a cool story and it's very powerful. And what excites me and why, when Ben asked me to bring this up, is there's been major attention in this. Since 2019, some of the biggest names in our orthopedic domains, people like Chad Cook, Paul Hodges, or as we call him jokingly, Sir Paul Hodges, guy with 3 PhDs, super smart, by the way. Joe Nice, one of the pain guys in Belgium, whatever. But some of the more important people started saying, wait a minute. These guys that figured something out right around 2009 to 2012, they're onto something. And they started getting involved in this, which is super, super cool for us in the orthopedic realm. But then what also happened is in 2020 up until 2022, and by the way, I can expand the slides out, there is now that research is showing up in the medical world. And why am I so excited about it is because if we and our providers, the physicians, can start speaking the same language when it comes to pain, I think the opportunity to truly impact people's lives are staggering, because otherwise it's just a bunch of us that in the clinic doing a little bit of pain stuff. And I think this is a really big deal. The American Academy of Orthopedic Manual Therapy, AOMT, is every year, is our annual manual therapy conference. This is now, for the last 3 or 4 years, I just checked, is a topic that is a hot buzz. And so it is a big deal happening right now. So let me share with you what this is. We now know there are really only 3 kinds of pain you're going to be dealing with every day in the clinic. Nociceptive-driven pain, which is really your tissues that are innervated, your peripheral nervous system, which is peripheral neuropathic, or then the central nervous system is going to drive the pain experience. The old name, central sensitization, the newer name, nociplastic pain, and that's a story all by itself. But I need you to understand that pain isn't pain. There are different kinds of pain. And what's very important tonight is we examine them different, we treat them different, we screen for them different. It makes a significant difference how we manage these patients in these various stages. So let me quickly run through it. Nociceptive pain is what I call your bread and butter. If you don't know this, you shouldn't be here tonight. This is going to put your kids through college. It's going to buy a next Lamborghini. It's going to buy you that house in the Hamptons, whatever therapists do with all their money. But this is, you guys know this stuff. I will actually come and take a course from you to learn about the rotator cuff and the SI joint and the ACL or whatever. We refer to this as nociceptive-driven pain. Now, Keith Smart told us a few years ago that if a patient shows up with this cluster that I'm going to go through right now, it's 100 times more likely that you sit in what we call bucket number 1, nociceptive, versus the other 2. So how does nociceptive sound in the clinic? The pain is proportionate. The input is proportional to the output. So grade 1 that you push on somebody's ow, grade 2 is double ow, grade 3 is triple ow. It's linear, and it makes total sense, right? It's the McKenzie strain model. The more strain you put in, the more symptoms you get. There's aggravating easing factors. So I turn my neck to the right, it hurts. I turn my neck to the left, it feels better. I raise my arm, it's worse, arm down. You guys should be able to identify this. Intermittent sharp, dull ache or a throb at rest. And the last one, no neurological, no numbness, no tingling, no pins and needles. You guys know this. If I tell you that if I walk down the street and my foot starts tingling, there's not a single person tonight listening to me that says that's a ligament. You're thinking vascular or nerve, right? We know this stuff. So I want you to kind of sit wherever you're sitting tonight and just reach back and pat yourself on the back and say, I know this. Yes, you do. You're really good at this stuff. So the first category is nociceptive. We know it. We've studied it. We're very good at this. The second category relates to peripheral neuropathic pain. This is where the peripheral nervous system drives the pain experience. If you want to think about things like I said, lumbar radiculopathy, cervical radiculopathy, carpal tunnel, cubital tunnel. If you know a little bit about nerves and how nerves glide and slide a little bit, you will know how to deal with these patients. So how do they show up? Well, Keith Smart said if patients show up with the following cluster I'm going to show you, it's 150 times more likely that they sit in the middle bucket, peripheral neuropathic, versus nociceptive versus central. So how do nerves, if you will, sound in the clinic? They're in dermatomes. They're in cutaneous distributions. If you want to, tonight, you can cross that out and just write this down, like the book. If you ever have a patient says this looks just like the book, the dermatome, whatever, that's neuropathic. They're running those very specific patterns. They have a positive neurodynamic test. These tests we're doing, like upper limb straight leg raise, they can very quickly, with sensitivity and specificity, rule in or out the presence of a neuropathic pain condition. And then nerves tend to also become mechanosensitive, especially in areas that there are superficial. So the ulnar nerve at the elbow, the tibial nerve behind the knee, if you poke on them, they're actually quite mechanosensitive. And then the history sounds like a nerve, numbness, tingling, pins and needles. So again, if you know a little bit about how nerves glide and slide, and you've gone through this in your training, which you definitely have, you should know this category really, really well. The last one, we always jokingly say, right, the one that shows up on Friday afternoon. I'm not making fun of this, guys. I've dedicated my life to this. This is what I work in every day. But these are people that hurt everywhere. Nothing helps. They've been everywhere. The sad reality is they really need help, and nobody really helps them. And we are so well equipped to take care of them. So Keith Smart said that if patients show up with the following cluster, it's 486 times more likely they sit in that last bucket. So how does central sensitization, if you will, if you want to use a clinical term, sound like? Disproportionate pain. Light touch hurts. I barely touch the patient and say it really hurts. Like, whoa, I'm barely touching them. Disproportionate aggravating and easing factors. What does it mean? Everything hurts. It's not rotation to the right. It's rotation to the right, rotation to the left, extension, flexion, everything hurts. Diffuse palpation tenderness. So in this little drawing in the middle that you can see, a patient comes with the right shoulder pain. You poke on their right shoulder and they say, ow, we expect that. But now you go to the other side and you poke on it and they say, why are you touching it there? Why are you touching my arm? Why are you touching my leg? That's local sensitization. In central sensitization, I poke on your right shoulder, you say, ow. I poke on your left shoulder, you say, ow. I poke on your leg, it says, ow. In the old days, we'd go look for problems wherever I poke and it's ow. But now the smart clinician, the modern pain-informed, will take a step back and say, no matter where I poke, they're tender. That is a hallmark of central sensitization. And then very important, they also bring in psychosocial issues. And the most common ones we'll see in clinical practice would be high levels of fear avoidance, catastrophization, kind of giving up, right? And then depression. And we can screen for those. So if you take all of those and you put them together, and I put this slide in here because this is the original work from Keith Smart, and I want you to notice at the bottom, it shows you sensitivity, specificity, and the odd ratios. Why am I showing you this? Because I didn't sit one night with a couple of my friends having a few beers going, yep, yep, no, and just put them in buckets. This is statistically calculated. And that is very important because, again, this isn't just, it sounds good, cool, Adrian. The research checks out and has been since been tested and tested and tested and tested. In the most basic way, we talk about buckets. And I'm sorry, it probably doesn't sound right, but I talk about to students all the time, to residents, fellows even. There's 3 buckets. If it sounds like this, it's 100 times more likely it fits in bucket number 1, 150 and 486, or almost 500 times. And that, at least for me clinically, that makes sense when I see patients come in. Now, the interesting thing is people don't sit in one bucket. Our patients are never simple, right? They don't sit only in one bucket. A patient may show up and have a lot of characteristics of one of the buckets, but have a couple of other things going on. If you look at this pie chart, which is really how people show up, you have a patient with lots of nociceptive, but there's a little bit of nervy stuff going on, and they may have high levels of fear. So we will, in this case, say this is nociceptive dominant, and we address the dominant factor first. So if this sounds like, tastes like more nociceptive, we will treat it as such and then monitor him over time. By the way, pies change. This is really cool. The nervous system itself changes all the time, right? Neuroplasticity, you've heard about bioplasticity. Your nervous system constantly changes, which means your sensitivity, which is also your clinical expression, changes all the time. What does this mean? Patients can get worse, but they can also get better. That is really important. You mean we can shift them the other way, Adrian? Absolutely. Can we shift them the other way? Absolutely. So we need to understand they are dynamic as well. We're doing a really cool project right now with our residents where they're actually having patients, we fill in the buckets, if you will, then we treat them, and along the path, we measure the buckets and watch how they shift, and then see what shifts them in which direction. So really, really cool stuff happening, but it is absolutely dynamic. Now, here's the important side of the night. Tomorrow is Wednesday. Yeah, okay, Wednesday. Tonight's Tuesday night. Tomorrow, Wednesday, you walk in the clinic and you notice you have 3 new back evaluations on your schedule. One is at 8 o'clock, one is at 11 o'clock, and one is at 4 o'clock in the afternoon. But there are your patients' pie charts, or their pain charts, if you will. I want you to know that these 3 patients, that each one of them comes in with a script that says back pain. They are very different people. They present different, you examine them different, and you treat them very different. The reason we're struggling so much with pain in this profession is that we have developed techniques that work for bucket number 3 that you're trying to do in bucket number 1, and vice versa. And it will not work. Patients will get mad, they'll get frustrated, you'll get frustrated and say, I hate this job. It doesn't have to be that way. This is really a cool clinical presentation. Now, just to put this in perspective, we have really good data to show you guys today in outpatient orthopedic practice in America. 55% of people sit in bucket number 1. And I cannot hear you guys right now. I think Ben has it all muted, so I'm hoping I'm hearing yay, because that means what? More than half your day should be your bread and butter. Guys, you shouldn't be working that hard on a nice, benign, simple rotator cuff tear or an ACL injury. You do nice, solid therapy. There's no fear. There's no catastrophizing. They're happy to be there. They want to do therapy. They do great. 25% of our patients are peripheral neuropathic. So as again, if you know a little bit about how nerves slide and glide a little bit, you can handle them. So if you time out real quick on a Tuesday night, 80% of your patients should be easy. For me, that's great news. Unless you work in a clinic like I do in chronic pain every day, then it doesn't work that way, but that's okay. That was my choice. That's what I wanted to do. 1 in 5 people that walk into your clinic on a normal, typical day would sit in the last bucket, which is really cool. I mean, it's only about 1 in 5. That's not that bad. So if you do just a normal outpatient therapy clinic that sees backs and necks and knees and shoulders, this is actually, for me, a very cool slide, unless you work with a very complex population. Now, what I want you to know is that those categories should drive all the screening tools you give people, the questions you ask people, the physical exams you do, and the treatment. And so for the rest of this presentation, real quick, I just want to quickly show you what that means. How do we screen somebody in bucket number 1, 2, and 3? What questions do we ask people in bucket number 1, 2, and 3? What kind of tests do we do for bucket 1, 2, and 3? And how do we treat them? Because if we can start matching the treatments and the examinations to the buckets, I do believe we're going to get better. And we're going to actually, all of us, take it here to the next level. So I made an assumption tonight, and I apologize a little bit here, but I would assume that in most clinics in this country, this is the kind of stuff we gather when a patient shows up at visit number 1, right? We get demographic information, male, female, whatever the case may be, age, gender, all those things. We get their insurance, we get a medical intake and review of systems. That's classic, right? We all do that. We ask pain ratings. Now, that's a topic all by itself if we should be doing it, but most clinics do, and we should, because our insurance carriers won't pay us. And then we all measure function. You have to measure function because Blue Cross will not pay me if I don't measure function. And I mentioned some of them, right? Maybe the Oswestry is something used for back pain, or the Roland Morris disability. For the neck, the NDI is pretty well established. Upper extremity, you may do a dash, a quick dash, or whatever your scale is. And lower extremity functional scale is an example. So we use these scales. You use whatever you were told to use in your residency, wherever you work, or whatever your hospital system is using right now. Now, I added one just because I'm hoping tonight I'm talking to progressive therapists, which I know I am. But if you're practicing in 2024 in an orthopedic musculoskeletal realm, it is very common also to ask fear avoidance. So it's not uncommon to get a fear avoidance belief questionnaire or a Tampa scale of kinesiophobia. So I'm just making an assumption tonight that most of us gather that information or something like that. So hopefully Adrian is okay on a Tuesday night. I figured it out. Now, If you really want to go to another level and you take more courses from somebody like an Adrian and talks about pain, you may hear things like, hey guys, we should screen for depression. During COVID, APTA and ACOTE came out with position statements that we should screen for depression. There are 2 questions we should ask from PHQ-2. And so maybe your clinical organization right now is asking these 2 questions. And by the way, a lot of it's about safety, to make sure they're safe. If they're not safe, let's get them some help. And then in the pain world, the biggest questionnaire that's probably out there for us is a pain catastrophization scale. Horrible name, by the way. They're renaming it right now. I don't know what the new name is, but I hope it is. Just tell us how you're feeling today's scale. But the pain catastrophization just tell us, have you given up? Are you like, that's it, life's over, bury me now. I got a bad back, I'll never walk again. So I apologize. But so in the pain world, that one's important because it tells us kind of where they see everything. All right. So here's the important part. Watch this. If you look on the left-hand side, there's information you guys gathered. You will then probably get out of that information things like the duration of the pain. When did this start? Where is it? Maybe a body chart. The severity of the pain, 6, 7, 8, 9, 10. You'll get something about fear, pain behavior, depression, catastrophization. You already, by just your intake information, would have more than enough information to already start figuring out which bucket they're sitting in. And that's important because a lot of people say, well, we cannot do this. We're therapists. We don't do MRIs, CAT scans, blood work. You don't need it. Pain mechanisms do not need any of the fancy scans. That's the cool part with this. By the way, I will never not use this opportunity to tell you guys that pain ratings, and we can talk about it all night long, I'm not going to do it, that a score of more than 5 out of 10, by the way, has been shown very strong evidence to drive prolonged recovery or a very poor prognosis. So as people give you information, you need to make meaning out of it. What does it mean if somebody rates it pain 6 or 7 or 8 or 9? And by the way, we don't own a painometer, right? I asked Ben, what's your pain rating? 6, and I don't have a thing I can push on his back. It's only a 4. You're lying, Ben Keaton, right? Pain is a subjective expression of how something is impacting you on that scale. So how people see it impact them drives actually how they will recover. So we do have to make sure that we ask these questions. These slides, I'm not going to necessarily run through. Julie Fritz covered some really cool stuff to show us there are cutoff points. I want you guys to keep this in the back of your mind, that if you give people these questionnaires, if they score above these numbers, they're going to take longer to recover. It's going to take harder to go back to work, and they need more comprehensive therapy, like multidisciplinary, interdisciplinary, or if you do therapy, you want to add things like cognitive behavioral therapy, pain neuroscience education, more advanced skills, because they need more of that. PCS, more than 30. And again, I do not expect you guys on a Tuesday night to remember these, but I wanted to put them in your handouts if you ever see these scales. The PHQ-2, there's the 2 questions we should be asking people. If you score more than 3 on that scale, then you probably have a major depressive disorder. It's questions about little interest in pleasure of doing things, or you're feeling down or depressed in the last 2 weeks, those kinds of questions. But again, as a resident into residency, tip of the spear, best of the best, these are the things we must ask because we are often the ones that's going to pick this up. In the pain side, there is another questionnaire called the Central Sensitization Inventory, guys. It's got 25 statements about pain, 0 to 4. Highest you can score is 100. Anything over 40, you're probably sitting in bucket number 3. So there's scales we can use to guide us to where people show up in these buckets. Subjective. The most common questions we ask in therapy is the old Maitland questions. What brings you here today? Is it typically pain, stiffness, loss of function? Your history, how did it start? How did you get here? Did it get better, any worse? Where is it? The site of symptoms, what makes it better, what makes it worse? And then we ask a series of questions to check for things like safety, right? Bowel and bladder, night pains, all those kinds of things we typically do. Now, here's the important things. If you guys look at these buckets, I just broke them down for you here again. There are 11 things here. There are 11 things that put you in your buckets. And if you watch very carefully, 9 of the 11 you can figure out subjectively. So you actually get most of your information through the subjective questioning. And so if I was sitting with a patient, I want to ask questions about irritability, about what makes it better, what makes it worse. Actually, to be honest, guys, it's the same stuff you've been trained to ask. Where's your pain? Does it go anywhere else? Does it go below the knee, above the knee? What makes it better? What makes it worse? And that's really what it is. You are so well set up for it, right? Then the physical exam. How do we do physical exams of patients? Well, regardless of what bucket you sit in, we always have to check safety, right? So I don't care which bucket you're sitting in, you always have to check things like Babinski, Clonus, Hoffman's test, sensation, strength, reflexes, vascular, pulses, temperatures, vitals, blood pressure. So whatever you were trained, we always check for safety first, right? To make sure they're good with us. Then we go about our exams. For bucket number one, physical exam, how do we treat these patients if nociceptive? How do we examine these patients? Anything you want to do. Your typical orthopedic assessment. You can push them, poke them, prod them. They're not going to flare. They're not irritable. You push on the hip. It hurts. You take pressure off the hip. It feels better. These are the favorite patients in the clinic, guys. They are so predictable, if you will. I take your shoulder, I load it, it's painful. I take your shoulder out of that position. They say, that's better. It is, oh my God, that's amazing. By the way, this is coming from a therapist that don't work with these patients anymore. I miss them because every patient I work, you can barely touch them, you can barely move them. Thinking about movement hurts, etc. They're more likely to delve into your special tests, your combined tests, your sustained testing, because you really want to find what's going on in that joint, the muscle, the tendon, or whatever. We don't expect a lot of latency. When you push the joint, it hurts. You take the load off, it's better. There's really no glowing effect after we typically see with them. How do we examine bucket number two? Well, first of all, you do a thorough neurological screen because you're talking about the nervous system. So you check strength, sensation, reflex, right? And you guys should be really good at that. And then we do neurodynamic testing, active or passive. And you can do them in different sequences. Bob Nee has shown us several years ago, you can wind up the nerves from proximal to distal, distal to proximal, depending on severity and sensitivity of an area. But if you know about the upper limb 1 and the upper limb 2 and the 3 and the straight leg raise and the slump, you can pat yourself on the back and say, hey, I know how to check that. A neurodynamic test is nothing else than a check of the mechanosensitivity of the nervous system to movement. And you guys are well trained to do it. And the more newer things that are showing up is nerve palpation. As I said, there are places in the body that nerves are very superficial. You can poke on them a little bit. And if you want to get really good, you can get a pressure oximeter, which is a little gauge that instead of me poking on Ben's elbow, I take the gauge and I put it on the elbow and I push until he says stop. And there's a number. So now I can measure it. So if you read pain articles, you'll pick up pressure oximetry a lot. It just gives us an objective measure of how much we can press on an area. And it's typically that when pressure changes to pain, that's the difference. So I press it, you feel the pressure, but as I push, it becomes uncomfortable. That's the point we say, tell me when that is, and we can measure it. By the way, if I treat you, I should be able to press harder because your system calms down. That's the beauty of it. We can measure it. And then the last bucket, what do we do with these patients that hurt everywhere? Nothing helps. They're super sensitive. Well, let's have a look. All the research strongly suggests low-tech functional movements. Don't worry about details. If Sally walks in your clinic with fibromyalgia, she hurts everywhere, she cannot sleep, she's very depressive, how much C3 slides on C4 means absolutely nothing in the big scheme. So we don't worry about minutiae or details. We think big. Can Sally move? Can she get out of her car? Can she go from sit to stand? Think more functional as opposed to more specific, right? Functional strength versus manual testing, large physiological movements, observe transfers, mat mobilities, balance reading. One of the best tests, by the way, for chronic pain would be a timed up and go, or a 1 minute sit to stand, or things like even your 40-meter self-paced walk test. Think more functional based testing with them. Be careful with special tests because they often combine things. They have things that combine movements, and that will just flare them or sustain movements. Be careful of those. Thorough neurological screen for safety, and then you're going to be looking for some sensitization of that nervous system. Okay. And then it can also be some plasticity. That has to do with their maps on where they feel their pain. The pain is spreading, it's bilateral. It doesn't fit your patterns you typically see in the clinic. And then the final one, everybody always asks, Adrian, how do I treat these patients? Well, that's pretty easy, right? Bucket number one, whatever you were taught in school. These are the patients, you lay them on their side, you crack their back, and they sit up and they say, oh my God, Ben, you're the best therapist in 9 counties. I'm going to send my whole family to you, right? They love it. They want it. They do phenomenal. Mobilization, manipulation, exercise, all your physical treatments, they do great. You can apply pressure. They often will be the ones that say it hurts so good. The harder you push, you're like, oh, it feels like it needs that last bit. Go for it. Not a big deal. And sustain combined movements. People have asked me, do we do pain neuroscience education, teaching people about pain in bucket number one? Typically, if they've got high fear or catastrophization, yes. But if I have a volleyball player at walking in, she sprained her ankle, she's not a fear avoidant, she's not catastrophizing. To teach her about pain would waste her time. I need to work on balance, proprioception, range of motion, get on her back on the court as fast as I can, right? But if she's fearful or catastrophizing, that's it. My season's over. I will not be able to play. I need to do some cognitive intervention. So sorry, I snuck a little bit of P&E in there because people know me as the P&E guy. But we just actually last week published a really cool paper for P&E for acute pain in a sports journal. And it talks about this, that if an athlete comes in a fear or catastrophization, we tend to do that. How do we treat peripheral neuropathic pain? Nerves need three things to make them happy, guys: space, movement, blood. It's as simple as that. If nerves don't have space, think about stenosis, carpal tunnel syndrome. They're not happy. Blood, they love blood around them, and movement. Nerves work like wet spaghetti. So if you give the nervous system what it wants, it beautifully dampens down. Be careful of overpressure or pressure on the nervous system because they have latency. They glow a little bit later on, but they like movement. A lot of those things, sliders, tensioners, space, movement, blood, a little bit of education so the nervous system calms, those kind of things. And then finally, how do we treat the last bucket? There it is. To treat people in chronic pain, you need to do three things to change their life. You got to change how they think, got to move them, and got to calm the nervous system down. Guys, we need to stop researching this. It's been published. It is so well understood. Cognitive, change how they think. You guys can use anything from cognitive behavioral therapy, pain neuroscience education, motivational interviewing, trauma-informed care, whatever your thing is. It just happens to be that in my world, pain neuroscience education is a thing we're teaching, but maybe you have a strong background in CBT or MI or positive psychology. Got to move them. I don't care how you move them. It can be traditional or non-traditional. And there's, by the way, some of them are better than others. Doesn't matter. You just got to move them. And then what you're going to see calming the nervous system, what I've listed there for you is a series of things that we've shown that turns the brain's chemistry back on again. It turns on the endogenous systems, your enkephalins, endorphins, serotonin, opioids. If you pick carefully from these three buckets at a consistent rate in the clinic, you're going to help that person change their life. No doubt about it. You cannot just do one of them. I've done it. I've taken people with chronic pain. I did manual therapy with them day in and day out. It's only one piece. It's only one leg. You got to do the other parts as well. All right. So then I don't think I can speak any faster than that. But the idea was that they will get a handout, and just thought I'd get to a point to where we can just maybe answer some questions or some
Well, yeah, that
comments.
was absolutely fantastic. I'm hoping there are lots of questions getting queued up. So on the chat, you guys should all have access to the chat. Please feel free to start typing some questions in the chat, and I'll get it started while people write their questions. So Adrian, I saw the graded motor imagery come up in a couple of those buckets. Would
Yeah.
you talk through that a little bit, just for those who are unfamiliar with it?
Yeah, in the simplest way, graded motor imagery is a series of techniques, a collection of techniques that is designed to reorganize the cortical maps of the brain. We now know that when people are in pain, they don't move much, and the maps in our brain changes. And graded motor imagery is just a sequence of techniques we use that can restore those maps. So things like laterality, making sure you're good at left and right, using mirrors to actually, for a lack of a better term, trick the brain to where body parts are, motor imagery where they can imagine movements before they move, those kind of things. Those are strategies to actually sharpen these maps in the brain. And when they map sharpen, the pain actually eases because the brain becomes more aware of its own body, if you will. So, and there's really good evidence for CRPS, phantom limb pain, and chronic low back pain. Those are the three key areas that has got quite a bit of evidence right now in the literature. Yeah.
And to follow on that, tell the group a little bit more about the use of like mirror therapy and things like that.
Yeah, mirror therapy was designed way back. Ramachandran is the guy that came up with it in California, just really cool neurologist. But mirror therapy basically helps us to replace the mental imagery of a painful body part. So if I've got CRPS of my hand, one of the most painful conditions, my hand is swollen, it's purple, thinking about movement causes enormous pain. It flares massively. If I now put a mirror between the two hands and I can project this hand with a mirror on the other side, now my brain sees this hand on the other side. The hand looks good. It's not swollen. It's not red. And when it moves, it doesn't hurt. As simple as it sounds, the brain goes, hey, I must be okay. Now, it's more complex than that, but the nervous system calms. It's a dampening technique. There are many other techniques, but mirror therapy works really well for us as a way to calm the nervous system down. Yeah.
That's fantastic. And it looks like we get our first question. Thank you for breaking it open. He says they work at the VA, get lots of vets with nociplastic presentation. When they have 20, 30 minutes per session, I find it very difficult to fit those three pieces you mentioned in regarding treatment. Any advice on how to manage?
Yeah, Roy. The cool thing is, I mean, first of all, I feel for you absolutely. Um, what I'm saying these days is this: with people with chronic pain, the bad news is they they have not been helped a lot. The good news is the bar is so low. We did a study recently to show us that when we're with the patients, time actually isn't the variable. Yes, we all believe more is better, but what all the data is showing is if you're there, be present. So if you have that 20 minutes or 30 minutes, be there. Now, can you pick from three buckets in one session? No. But can I do one piece in the clinic, but send you home and say, go read this, or hey, here's a link to this YouTube channel, or hey, there's this cool app. And by the way, don't sell yourself short. We just did a survey of all the pain apps in the planet. The VA's pain apps, Ben, I'm going to be kicked off of this, but is kick ass. Sorry for the words, but the VA's pain apps are some of the best on the planet. So it could be that you go look at those resources and say, hey, Frank, whatever the veteran's name is, I'm going to work on your back. Let me do the physical stuff in the clinic because that's what I'm good at. But I want you to go home and check out this breathing app or this mindfulness app or this sleep app. Now you're actually using technology to help you, right? But all I'm asking you that if you're going to see him again and again and again, we cannot only pick from one bucket. So if you only do manual therapy every time, it won't work. We need to do manual, but then maybe do a little bit of this with this, but so we can rotate around. I'm with you. More time is always better, but our data would just say if you're there, be there, do your thing, connect with them, and then maybe think of some extended treatment. So I hope that helps. It sounds very cavalier, but that is typically what we see. Yeah.
Love it. Next question is, what is the typical time frame or expected number of visits on average to expect either change in symptoms or full recovery for someone in the central sensitization bucket?
Yeah, Curtis. The answer is yes. Next question. Curtis, honest to God, you can literally come spend time with me in the clinic, but I'll tell you, I've had patients in one visit go, I got it. And you know what it means? They saw some amazing therapists that did all the right pieces, but they missed one puzzle piece. And then Adrian, super duper guy with pain that speaks funny, walks in and I say the right thing and it just click. So I can tell you, I can show you a video right now of a lady that was going to, I don't talk a lot about this stuff, but she was going to commit suicide. She came to therapy, said, if I don't get help today, I'm done. And she met a therapist. I got the video. We were able to interview her. And that therapist just walked in for one session, sat with her and told her about pain, how pain works. And she started bawling. She said, oh my God, this makes sense. And saved their life, changed their life. So that was in one session. Now, your question is a little bit more complex. Most of our patients don't work that way. We would see a patient probably in our clinic once a week. Because they're chronic, we don't have to see them twice a week, but once a week. And we'll see them over a period of time. I mean, I may see them once a week for 4 weeks. Then we see them once every other week for 4 weeks. And we stretch it. So I may, over a 3-month period, only see you 8 times. But we give people a lot of homework. There's a lot of things they have to work on. There's sleep programs, there's walking programs. We check in with them. So think more in terms of duration over time versus more therapy isn't the answer. They typically had more good therapy. We just need to sequence a little bit better for them. And yeah, it's a great question, but it takes time. And by the way, the bigger question is, what is better? It's not pain free. It's when they can get on with their life and say, you know what, I can do this at home. Yes, you can. We make them independent, right? That's the goal. I know it sounds kind of cavalier, but yeah, most of our sessions take once a week over a period of time that we will see them. Yeah.
Next question is, let's say there's a patient with equal in each bucket. So do you recommend treating one type over another?
Yeah, that's a really great question, Josh. I don't ever recall seeing 33 and a third, 33 and a third, 33 and a third, but I'll take you on that story tonight. If I had that, I would always err on the side of caution. because if I push you too hard, the central side will flare, no doubt. So I would rather do more centrally based stuff to calm you down and see if things will shift. So it may be that at visit one, I teach you about pain, I do some breathing relaxation, maybe some mindful techniques, and see if your system calms. You walk in the next time, oh my gosh, I feel, I'm so much more relaxed or whatever. I may then do manual and see how do they respond to my manual, those kind of things. The other answer to your question could be I can ask the patient, what do you want me to do for you today? And that list that I gave you guys, we have it on our letterhead. I've given it to a patient, say, is there's anything here excite you? Anything here that you would like me to do? Oh, what's sleep hygiene? Well, let's talk about sleep. Yeah, manual therapy. Yeah, I need you to crack my back. Okay, we can do that. But I wouldn't just go lane and crack you. I would do some gentle manual techniques and see how you respond. Because if I figure out there's a little irritability, I wouldn't go ahead and really do it. So it's a little bit of that reasoning in between. These are, by the way, you guys are asking way too smart questions on a Tuesday night. That's great questions.
It's a good group, Adrian.
Yeah, they're
so
phenomenal,
Taylor asks,
man.
with body awareness and things like neurotherapy, which are often used post-CVA, is there evidence to work across the body or midline to assist with body awareness as well, like you would post-CVA?
Yeah, there's amazing research coming out of Italy's research team that shows us not only does my brain know this is my right hand and my left hand, it knows that this part of my body belongs to my right hand, this part of my body belongs to my left hand. And if I cross them over, so I'll give you guys an example. If I had CRPS and this hand was cold and it's swollen and painful, if I cross my hands across the normal hand that goes into that space actually gets cold. So the hand adapts to the area. The swelling goes down. It's absolutely phenomenal. It's really cutting edge stuff. So in hand therapy, we have now taught hand therapists when they do hand therapy based stuff to always cross their hands, because there's an analgesic effect to crossing your hands in very significant neuropathic pain states. So yeah, the crossing the body line midline is a potential strategy for people with pain, neuropathic pain especially. Great question. Wow.
Next one, would you recommend or advise against explicitly describing or telling patients the 3 general treatment strategies, movement, thinking, calming, as part of the patient education for nociplastic pain?
Emily, that's a great question. I've never thought about it, and we don't do it explicitly that, hey, what I can offer you sits in 3 buckets. We don't do that. What we've pretty much done is, if you look at that slide, and you guys will have a handout, most of what's on that slide, we actually put on a letterhead, and if you counted, there's about 22 different things there. I only put stuff on the options for patients that I can do. So it wouldn't help you to put mindfulness-based stress reduction on if you have never taken a mindfulness course. So I encourage therapists to look at the list and say, what do I feel comfortable with in the clinic? Then create your list. Maybe your list is 10 or 12 or 13 or whatever things, and say, hey, Susie, these are the things I can do for you right now. Is there anything here that you would like to try? And that's typically where because it gives them an option. Now, if a patient sits there and goes, nope, 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 you have a behavioral problem, which means we need to put on our big boy pants and have an adult conversation about, I can only meet you halfway, right? I'm here to help you. And that's a different discussion on a different day. But I've never ever told people there's 3 buckets. That seems a little, I've never done it. I've never thought of it. Maybe we should try it. But I just tell them these are the things I can do for you. And by the way, just to be transparent, Emily, on that list that we give patients, there are some of them are bolded, which means those are ones that I say you can pick anything, but these we will do at some point. And that is pain education, sleep, movement, and goal setting. Those are the 4 pillars to recovery. So I tell patients, you can pick whatever's on this list. I don't care. But at some point, I'm going to teach you about pain. We're going to move you. I got to work on your sleep, and you have to have a reason to get out of bed. Those are the 4 big ones. So yeah, great question. I never thought of it. That would be a residency project for you, Emily.
Next question. There was some mention in the ortho current concepts about TENS to calm down the nervous system in cases of central sensitization. I can't recall the exact reasoning, too many readings, but do you use this at all in your practice?
Yeah, I'm aware of it. I mean, to be full disclosure, I know the scientists that do that research, they do great work. My concern with central sensitization has always been it's a central mechanism. So where am I going to put the TENS unit, right? And I would say, well, if the manifestation is it hurts in your elbow, put it in the elbow. What I like about TENS is gate control is old. It's 1965, Melzack and Wall, but it's still valid. the physiology still works. So that's cool. The biggest thing about TENS that I do like is you empower the patient to help themselves. They do not have to come to the clinic to be hooked up to your eSTEM unit. So I like TENS because it creates independence. TENS units, just so you guys will know tonight, if you do give patients TENS, TENS should be worn based on function, not on pain. What does that mean? We don't tell people put TENS on when you hurt, because then all they do all day, they wonder, when do I hurt? When do I hurt? When do I hurt? They focus on their pain. You ask them, Sally, when does your back hurt the most? Well, when I stand in the kitchen and I cook dinner, my back hurts. Okay, whenever you cook dinner, standing in the kitchen, you put TENS on, regardless if it hurts. Because now you focus on what you're doing, not on your pain. Because if you constantly focus, when do I hurt? When do I hurt? The system will just keep ramping up. But I like TENS because it's independent. If the patient can help themselves. So I'm a fan of it. It's just a way for them to help themselves. So I don't have a problem with it. It's a piece of the puzzle. It's not the whole piece. Yeah, great question.
Kristen says, I have a current patient who I know has central sensitization, who I've done a lot of PNE already with, thanks to your previous courses. We recently discussed some of his stressors, and he mentioned financial stressors related to not working for the last 2 years. As we dove further into this, he expressed he's not working because he's waiting to hear back regarding whether his disability claim gets approved. I'm wondering if this may be driving some of his symptoms, and I'm struggling with how to manage this case any further. Any recommendations?
Kristen, so the question should probably be, let me start with the question behind the question. Who responds well to PNE? We have spent the last 5 years doing that research. The following people do great with pain neuroscience education. People with central sensitization, that's that last bucket, check that box. People with chronic pain, they've had pain for a long time because they have more doctor's visits, more ideas, thoughts, whatever. People with high levels of fear and catastrophization. So those are the big 4, right? There's number 5, people that are not in pre-contemplation. Pre-contemplators are people that don't want to change. Hear me correctly tonight, guys. They're not bad people. You're just catching them at a different part of their journey, right? How does it sound in therapy? I'm only here so the doctor will give me my medicine. I'm only here because work comp sent me here. I'm only here because my wife gets my wife off my back. This person you're describing is not a bad person. The system that we work in is probably the bad system. You won't change it. I won't change it. Ben's not going to change it. I work with the person. So I swore an oath to my patients. So if I find that I do a cognitive intervention, but you're not really shifting, and I find that's one of the reasons, that's okay. I would then turn to the patient and say, no, what would you want? What do you want me to do in therapy? Right? I've had many people walk in. I'm only here because the doctor was sitting here. I don't want to be here. Right? Then all I do is, first of all, I treat him with dignity, respect, and compassion. And I do very benign, simple movement-based therapy, simple stretches, nice, basic, simple stuff. And oh my God, Ben's recording this tonight, but I slap a nice old hot pack on your back with Eastham and we're good. I don't hurt you, you don't hurt me, we're all good. But here's the mistake you make. Don't leave the room. I cannot tell you guys how many times I've had a truck driver on work comp sit in my clinic, and then I show him some very simple stretches, nice, simply, just basic therapy, slap a hot pack on his back, some Eastham, and I don't walk out, I sit down. And I say, so you're a truck driver, right? Yeah. Are you local or long haul? Now I'm using his verb, he's like lingo. And it's like, no, I'm local. Well, why is that? Why have you ever done long haul? No, I got kids. And then you say, oh, I noticed you got a Packers jersey on. What do you think about the Packers this year? And before we know it, we're having a human interaction. I cannot tell you guys how many times that patients turned to me and said, I'm sorry. And I say, why are you sorry? Yeah, I was kind of rude to you. I said, we're good. I'm just here to help you. How can I help you? And then they ask me, well, what do you guys do here for back pain? Well, now he's moving to contemplation. Say, well, in our clinic, we do manual therapy and exercise, but we also love for people to understand why they're hurt. You know, when you said when it's cold, you feel your back? I can explain that to you if you wanted to. Notice I'm not pushing, I'm just putting it there. But again, the systems are the systems, guys. Work comp, disability, whatever. In the 20, 30, 40, whatever minutes I have today with you, how can I make your day better? And if it's nice, simple stretches, some breathing, just a good old hot pack while we just talk about the Packers, you guys can crucify me. You can put it on social media all you want. That's just how it works. That's just so I applaud you for trying it. But if people are, or like in your case, the patient, you found the nugget. By the way, congrats for doing it because you have to dig a little bit. But if you find those, it's okay. Now you could go another step further and start having meaningful conversations. So I've had it, and I know there's questions, but I've had guys come to me in the clinic that was not going to go move. They don't move, they don't do anything because work comp. And I've had people get off the plinth and go back to work, not because of work comp, but we start having conversations about what kind of example they're setting for their young children. And they go, oh my God, what am I doing? Yeah, I'm sitting here waiting for my work comp, but my son is watching me not working. I've had guys literally, so your plan of attack may change. Now that's a different skill set, but sneaky in the clinic. But these are great questions. Ben, you didn't tell me it's going to be this hard. So great
Firing
comment.
squad, man. The residents are a different group.
Well,
For
yeah.
patients with Ehlers-Danlos syndrome,
Oh,
especially hypermobile type, it seems we are playing in all three buckets all day, every day. Any advice on how to optimally structure treatment sessions and expectations to best manage this condition?
that's a really good question. And you're very observant. They do oscillate because they oscillate from flares to not a flare and a good day and a bad day. I think you basically just examine them for what's in front of you today. And if they show up and they're flared up, they're probably closer to that last bucket, and we do those kind of strategies. For those kind of patients, I really think you need to think bigger scheme things: sleep, stress reduction, lots of education, those kind of things. And then if you catch them on a good day, today's a good day, well, let's work a little bit extra on your exercises today, or your stretches and stuff. There's a lot of things we don't understand yet in that space, but I think it's very observant where they are today, attack them that way today, and just carefully monitor. So great question.
I'm going to pull one from the Q&A section, just to make sure they don't get lost. Kristen asks, how would you recommend going about recording or describing the patient's pain presentation, the pie chart, in a systematic way in the patient's documentation?
Yeah, we never share it with the patients. I don't tell them which pie chart they're in or whether this is all for the clinician. So we don't go through it. I do it myself. So in the clinical setting, so I'll just tell you guys, I showed you that slide with the 11 little things with the buckets. For our residents, all we did is the bullet points became little blocks. So when the resident gets done with the patient in the room, they walk out and they quickly check and they can quickly see where most of the tick marks are, and that's the bucket. And then the clinician will go, but I don't tell the patient, oh, you're in the central bucket today, or oh, whatever. It helps the clinician. It's a great idea. Um, I have no idea if there's value to it. Maybe it does. Maybe you guys are onto something where we do go to patients, based on your clinical presentation, this is how you show up today, and we're going to be doing this. So maybe we talk about more of a tailored treatment, like, whoa, that's cool, right? Great idea. I've never thought of it. We've never overtly done it. You guys should not say stuff like this because I'm not going to sleep tonight. I'm going to think about a research project. So it's a great idea, but I've never tested it. So
Another question, this one from the chat again. What are your thoughts on virtual reality in treating chronic and nociplastic pain? Is this something you've had?
yeah, we submitted a paper yesterday morning on P&E and VR. So we have published about 4 or 5 papers on virtual reality. The VR space is interesting. So the grandfather, the Michael Jordan of VR, is Hunter Hoffman. He's one of the 2 only people in the history of medicine to be put on the cover of Pain Journal, which is huge. He built something called Snow World, which people with burns, for example, they put their headset on and they go through this little snow globe world, and they see little um, um, uh, ice sculptures, if you will, and snowmen and whatever. And they were able to calm the nervous system to do debridements and stuff. So that's kind of where VR started. VR has now progressed to where we're now getting into very advanced technology with 6 degrees of freedom, where you can do things like breathing relaxation, but also all the movements and those kind of things. The area we have done work in is to actually take some of these pain stories that I've developed and put them into virtual reality. So instead of hearing the story, you live the story. And we've been able to show that you can reduce catastrophization, fear avoidance, pain, all those things with VR and P&E. The way I look at it is not that it replaces a therapist, but it's an extender. So if I go back to my colleague earlier that talked about the VA, Adrian, I only had 30 minutes. If you go read the paper we submitted yesterday morning, what we did is in the therapy time, we did our normal standard therapy, which is exercise, movement, range of motion, manual therapy. But then they go to a treatment room and they do the VR where they do P&E and breathing relaxation. So now instead of giving somebody 30 minutes, we gave you an hour. And so now you have more of a robust treatment that actually picked from 3 buckets. So think of it as an extender. But the technology is getting there, augmented reality. It's scary where it's going to go, but it's also exciting where it's going. So it could be that there's things that you don't feel comfortable, like, Adrian, I'm not good at P&E. Well, just stick a headset on and let the VR do that for you. Adrian, I've never taken a mindfulness-based stress reduction course. Well, we can do it in VR. I think what will happen is we're going to end up doing the thing we do. I'm good at manual therapy. I'm good at exercise. Let me do the physical stuff. And these extenders, by the way, there's pain apps out there. There are websites there. So those are extenders, and VR definitely has, with the immersion and really targeting parts of the brain, it can potentially have a better effect than apps or YouTube or those kind of things. That's what the data is showing us. So great. Yeah.
I got maybe one or two more questions, and then we gotta give everyone their Tuesday night back, whatever's left of it. This one again from the Q&A. What would you do in an instance when you're working with an athlete whose natural response is to avoid their pain completely and push through it, which enables them to perform movements that are more harmful to the injury and slows down the recovery process? How do you reteach patients like this to use their pain as a guide rather than to ignore it?
Yeah, that's a really good question. The analogy of no pain, no gain is a very common Western American thing. Suck it up, let's get through it. That doesn't work for people with persistent pain. In an athlete that, Ben has an ACL high school kid that wants to get back in the field, push through it, push, push, push. Athletes are interesting. Yeah, they get lots of incentives to push. Right now, for whatever reason, I'm speaking to more NFL, NBA, Major League Baseball teams than I've ever spoken in my life, because these guys are extremely in tune with their body. They don't want to push it too hard, but they can push over. So a lot of it comes down to education, to understand their limitations. What I really find interesting right now is these professional leagues are spending zillions of dollars on things like sleep, nutrition, mindfulness. So the old days of suck it up, whatever, is actually being changed to more in tune professional athletes that are very in tune with their bodies. And what do I put in my body? How do I sleep? How do I rest? Whatever. So these conversations are getting better. So I'm mentioning this here. Why? Because when we work with the high school kid that wants to push, the best conversation is to tell them, do you know what the pros are doing right now? And that's what they want to hear. Well, the pros worry about sleep, nutrition. They monitor their body. If they push too hard, they pay for it. So now you have an in, because all of us want to be like Michael Jordan or LeBron, or, well, now everybody wants to be like Caitlin Clark, right? So let's give her dues. But I've had a lot of success with kids in pain doing sports by talking more about being in tune with your body. And if you push so hard, you're going to pay for it. That's fine. You can do it, but it's going to set you back. Guess what the pros are doing? And then their ears perk up. They're like, whoa, whoa, what are the pros doing? Well, they tease it, they touch it, they nudge it, and they back off and they go, I'm good today. Tomorrow we go a little bit further versus just go as hard. If you guys know it, Stanford University, I know we're at the end, their athletes have done extensive work on sleep programs where the old days was you have to burn the candle at both ends to get ahead of your competitor. And they showed by adding sleep, the swimmers' times of the blocks way faster, their speeds are faster, their three-point shooting on basketball. So I use examples like that to tell them it's not doing more or pushing harder, it's actually being smarter. And so I've had a lot of success with athletes actually responding to that today. What are the best people doing? Well, they're very in tune with their bodies, and they listen to it very carefully. So I don't know if that answers it. So
Fantastic. And I have one very important last question, Adrian, because I think you have piqued the interest of many, many people, and those watching the recording, I'm sure, are also very excited. Where can the people on this call and the ones watching the recording find out more information about this? Because I'm sure they have
yeah,
27 patients they're thinking of.
yeah,
How can they access you, the courses you've created, things like that, resources to help them?
yeah. So you guys have the handouts. My email is on there. You're always welcome to email me, by the way. I know a lot of people go, Adrian's so busy. Yeah, I'm busy, but I got a big team behind me. I got a whole pain fellowship. If you have a tough patient, email us. We can help you, whatever. I do work for Evidence in Motion, so that's where we teach our courses. But you guys will also see there's a QR code. There's a website. It's 100% free. It's called whyouhurt.com with a double Y, whyouhurt.com. It has dozens of videos of me teaching patients about pain. It's free. There's a whole bunch of links you can send to your patients. Hey, go watch this guy with a funny accent. So we built this site for you guys so you can have access to it. It's 100% free. I would definitely go there as minimum as a resource. So going back to our colleague that said, I only have 20 minutes in the clinic, you could maybe do your exercise and say, hey, go check out this video tonight. And when you come back Friday, let's talk about it while we do your exercise. So go to whyouheard.com would be a great place. Or if you want to email me, feel free to do so. Yeah.
Adrian, it is always a pleasure. I really appreciate you taking an hour to train, as you said, the tip of the spear. We're very fortunate to have you, and have a great night. Thank you all for coming.
Thanks, everybody.